Great, so good evening everyone, and thanks for joining us for this webinar and online workshop on asthma in pregnancy. Apologies for the sound there, I'll just fix that up. This webinar is kindly being hosted by Capital Health Network. So just before I introduce the team, we'd like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people today. So today's webinar is being brought to you by the Asthma in Pregnancy Research Group based at the Hunter Medical Institute and the University of Newcastle. We've been holding a number of ACT-based education sessions in the ACT across the year, which have been funded by an ACT Healthy Canberra grant. My name's Janet Bristow and I'm project coordinator for this grant and the Asthma in Pregnancy Toolkit, which we're going to hear about today. So our main presenter for this evening is Associate Professor Vanessa Murphy, who is a scientist with 20 years experience in respiratory research. Vanessa's research interests focus on the management of asthma exacerbations during pregnancy and their health impact on both mother and baby. Vanessa is a research fellow funded by an investigator grant from the Medical Research Future Fund. We also have joining us Professor Michael Peake, who is a RANZCOG certified maternal fetal medicine subspecialist with a 30-year career in clinical science, clinical service, research and education into medical disorders in pregnancy. He's Director of Research Development at Sydney Clinical School, working at Sydney Adventist Hospital, and he's also a Professor of Obstetrics and Gynecology at ANU. Kelly Steele will also be presenting today, and she's a registered nurse with over 20 years experience in respiratory research in pregnancy at Hunter New England Health and the University of Newcastle. Finally, we have Janine Lorenz, who will be speaking from Asthma Australia, where she's Health Projects and Partnerships Coordinator. So just finally, a little bit of housekeeping. As you can see, cameras and microphones are switched off, and we'd like to ask that if you do have questions, can you please pop them in the Q&A function rather than the chat function, and we'll try and answer them during the session, or we can follow up with you after the event. So you may have seen in the chat that there is a link to a pre-workshop survey, and we'd really appreciate it if you could fill this in. This is for our team's research purposes to inform future research and events. So now I'll hand over to Vanessa.
Thanks, Janet, and thank you everyone for joining us this evening. So before I begin talking about the Asthma in Pregnancy Toolkit more specifically, I just want to acknowledge the funding sources that we received to put together this toolkit and the education sessions that we're providing this year. So the toolkit itself was funded by a grant from the Clive and Vera Ramaciotti Foundations, and we have had support from the University of Newcastle, the NHMRC Centre of Excellence in Treatable Traits, and the Hunter Medical Research Institute. And the educational campaigns that we've been running this year are supported by the ACT government and Asthma Australia.
In Australia have asthma. 30 to 40% of their asthma could get worse during their pregnancy. And 1 in every 2 women with asthma can experience an asthma attack where they need to seek medical help. Help them manage it better with the Asthma in Pregnancy Toolkit. Well-controlled asthma is best for mums and babies.
Okay, so as you saw on that little video, 13% of pregnant women in Australia have asthma. Asthma is the most common chronic disease to affect women in pregnancy, and Australia has one of the highest rates of asthma in the world. Compared to women who don't have asthma during pregnancy, those with asthma are at increased risk of a number of poor perinatal outcomes, particularly preterm birth, low birth weight, and preeclampsia, as well as neonatal poor outcomes like being hospitalised at birth or being small for gestational age. In addition, children whose mothers have asthma are at increased risk of getting asthma themselves in childhood. 1 in 10 pregnant women with asthma may require oral corticosteroids for an exacerbation. And the number of women who seek medical help in general is much higher than that. Around 45% will need to seek help for an exacerbation in pregnancy. And once again, this increases further some of those perinatal risks, particularly low birth weight and preterm birth, and further increases the risk of the child having asthma. Asthma attacks are characterised by asthma itself is characterised by day-to-day variation in symptoms. And when these symptoms progressively worsen over time, this is called an asthma attack or an exacerbation or flare-up. And as in other adults with asthma and children, the main triggers for exacerbations of asthma are viral or bacterial infections, but these might also be related to factors such as allergen exposure, stress, or poor adherence to preventer therapy. A recent systematic review conducted by our group showed that there were 6 significant maternal risk factors for an asthma attack in pregnancy, and these were moderate or severe asthma compared to mild asthma, maternal cigarette smoking, slightly older age, maternal obesity, multiparity, and the mother having depression or anxiety. The main message for managing asthma exacerbations in pregnancy is that management should be the same as for other adults, including the use of oral corticosteroids if needed. This figure that I've just shown, and this next one here comes from an infographic that's on the Asthma and Pregnancy Toolkit, showing here the signs and symptoms of an asthma attack and some first aid advice if needed. So why do we need more information about asthma in pregnancy and to raise awareness of the issues of asthma in pregnancy? These are some quotes we received from women who were pregnant and had asthma when we were conducting some qualitative studies. And you can see that participant 10J, she wasn't aware that for some women their asthma is exacerbated by pregnancy. Participant 6J was short of breath all the time and felt awful. No one picked up on anything. They thought it just must be pregnancy. And this is commonly a common misconception that the breathlessness of pregnancy is benign, but perhaps in women with asthma it is more of a problem. And participant MD6, when she was 13 weeks pregnant, her asthma got bad quickly and she presented to emergency. They kind of looked over and said, look, you're okay, oxygen saturation is fine, sent me home with Ventolin. This is not what we want to be seeing happening to women who are coming to the emergency department. So there is a need for more awareness about the risks of asthma in pregnancy and how to best manage pregnant women's asthma. So this is one of the reasons why we developed the Asthma in Pregnancy Toolkit. We wanted to have a centralised source of evidence-based resources to support decision-making by health professionals and to provide information for pregnant women with asthma and their families. And the Asthma in Pregnancy Toolkit has been endorsed by Asthma Australia, which is the peak consumer body, as well as the Society for Obstetric Medicine of Australia and New Zealand. So I've mentioned the first of these goals already, raising awareness. We particularly were conscious that there were very few resources available for antenatal clinicians, including midwives and obstetricians, but also that more information was needed for GPs and practice nurses, pharmacists, as well as specialist physicians and nurses. We wanted to provide evidence-based resources and also a platform to disseminate new research findings in this area. And hopefully by having an online platform, this might support the care and management of asthma during pregnancy in rural and remote areas. So to start off tonight, I'm just going to give you a quick tour of the toolkit. So you can find this at asthmapregnancytoolkit.org.au. I'm going to run through the sections of the toolkit briefly so you know where to go back to later and find more information. And then we'll dig into the recommendations for management of asthma in pregnancy in more detail. So this is the homepage of the toolkit. You can see that there's a section for healthcare professionals and a section designed for families. The section for healthcare professionals is divided into 6 modules, an introductory section on asthma in pregnancy, a section on medications, a section on treatable traits, and I'll be talking more about these 3 sections as we go. There's a section on maternity care considerations, air quality, and COVID-19. So the asthma in pregnancy section describes the prevalence and burden, the risks to baby and pregnancy outcomes, and these are the things that I started talking about this evening. And there are further information about asthma symptoms and management goals. In the medications sections, which is one of the most clicked on sections of the toolkit so far, we have further information about inhaled therapies and oral corticosteroids, as well as monoclonal antibodies for asthma treatment, as well as medications that are used for common comorbidities such as rhinitis and reflux. In the treatable traits section, you'll see that we've divided this into pulmonary, extrapulmonary, and risk factors or behavioural traits, and I'll go through this in much more detail later on tonight. In maternity care, there's information around models of care, labour and birth, and breastfeeding. The air quality section considers both outdoor air quality and indoor air quality, particularly as they are triggers for asthma in many people. So things such as outdoor allergens and thunderstorms, bushfire smoke exposure and heat stress, as well as indoor considerations like cigarette smoke, allergens, and natural gas exposure. And the COVID-19 section discusses risk and susceptibility in pregnancy, vaccination, antivirals, and long COVID. There's also a significant section of resources, for example, infographics and videos, as well as clinical assessments like written action plans, etc. And in the For Families section, we've designed most of this around frequently asked questions. For example, will pregnancy affect my asthma symptoms? Is my asthma medication safe to take during pregnancy and breastfeeding? And we have short answers in easy to understand language. Here are some of the other FAQs. When should I see my doctor about my asthma in pregnancy? Is there any way I can reduce my baby's chance of inheriting asthma? What if I get COVID during pregnancy? Things like that. One of the resources in the For Families section is a one-page list of 6 questions that a woman could take to her doctor to ask more about their asthma, particularly things like, can you check that I'm using my inhalers correctly? And can I have an updated written asthma action plan? The Aboriginal and Torres Strait Islander resources are under development. We will soon have links to existing resources on this page, but we also invite Aboriginal and Torres Strait Islander women to share their stories to help us shape more specific messages for them and their communities. Okay, so that's the end of the toolkit tour. I'm now going to move on to talk about recommended management, and I will go through each of these sections in detail, but basically the recommended management for asthma in pregnancy comprises these 5 components: regular review every 4 to 6 weeks, the continuation of prescribed asthma medications, multidisciplinary management, particularly involving the obstetric care provider, management of comorbidities or treatable traits, and self-management education. So starting off with regular review. Asthma symptoms are known to change in pregnancy for many women. Traditionally, it was thought that a third of women got worse, a third improved, and a third stayed the same. And a recent study published in 2022 showed that there were actually 2 trajectories of change. 60% of women had no change in their symptoms in pregnancy, and the other 40% showed worsening asthma symptoms. Although interestingly, in those final few weeks of pregnancy, most women experienced a reduction in their symptoms. And these changes in symptoms are unpredictable from pregnancy to pregnancy and woman to woman. And that's the basis behind the recommendation of 4 to 6 weekly checkups. So asthma medication, this is one of the most commonly requested sources of information for pregnant women with asthma is around their medication use. And the key messages are that prescribed medications should be continued, that inhaled corticosteroids are considered safe in pregnancy and breastfeeding, and further information should come from discussion with the GP or respiratory specialist. So just before I talk more about medications specifically, a quick refresher on asthma and the lungs. On the left, you can see a normal lung where the muscle, the airway smooth muscle is relaxed. There's a normal amount of lining and mucus. And on the right, you can see the asthmatic lung where the airway smooth muscle has tightened, the lining is swollen, and this narrows the airways, and there's excess mucus. So asthma can be treated with bronchodilators. These drugs relax the smooth muscle in the airways, leading to dilation and opening. They're primarily beta agonists, which can be short-acting or long-acting, and the most common short-acting being Ventolin or salbutamol, and the long-acting beta agonists formoterol and salmeterol are used in combination with inhaled corticosteroids. On the Asthma and Pregnancy Toolkit, we have this table of common asthma medications, their mechanism of action and their safety. And this table has been developed using the information that came from a European Respiratory Society and Thoracic Society of Australia and New Zealand task force statement, which was published in 2020. And this statement has used terminology that you can see on the right-hand side of the table of compatible, probably safe, and possibly safe, where compatible refers to drugs that have had a long history of action and no adverse effects have been noticed. Probably safe refers to drugs that are of a similar type and therefore are likely to be safe. And possibly safe refers to sort of second-line treatments that have less evidence for their safety. And of course, in pregnancy, there are often very few randomized controlled trials of medication. And so the primary way that we understand medication safety comes from longevity of use. This table is going to be updated shortly with the Australian categories for safety. So salbutamol and terbutaline in Australia are both considered category A medications. If we turn now to the anti-inflammatory medications, they reduce inflammation in the airways, particularly eosinophilic inflammation, include the inhaled corticosteroids. They can also be known as preventers or controllers that are used long-term for the maintenance of asthma control. And as I mentioned earlier, can be used in combination with a long-acting beta agonist. So here in the table from the toolkit, we have information about budesonide, which is the only category A medication of this type in Australia. Flexitide, Symbicort and Seretide are considered category B3 in Australia. They're probably safe, but they just haven't been around as long enough, so there's less information available in the literature on their safety. So the key message for inhaled therapy is that regular anti-asthmatic therapy with inhaled corticosteroids and beta-2 agonists is safe and should be routinely used for asthma control to ensure less risk of adverse outcomes for the mother and fetus. When we consider oral corticosteroids, their benefit in severe asthma exacerbations is thought to outweigh any possible fetal risk. They should be prescribed as for non-pregnant women, in the context where the ultimate goal is to reduce the risk of an exacerbation occurring in the first place. So prednisolone is a category A medication in Australia. This is some data that's come from the US. It's a bit old now, but there's no more recent studies in this area. And it shows that women who are pregnant often are less likely to receive oral corticosteroids in the emergency department setting. They are less likely to be prescribed oral corticosteroids on discharge. And in these studies, they were more likely to have an ongoing exacerbation or to represent to emergency within 2 weeks. So as I said, there's no other more recent studies, and certainly there's no Australian data. I think it would be really interesting to know whether these type of prescribing patterns exist in our emergency departments. But certainly the recommendation is that pregnant women should be treated as non-pregnant women would be when they have an asthma exacerbation. Turning now to the monoclonal antibodies, these are more new medications that block specific molecular pathways involved in an individual's asthma. They are all considered category B1 in Australia, and there's not a lot of research data on any of these drugs. The most data we have is on omalizumab, where there has been a published pregnancy registry called EXPECT. This is from the US and Canada, and this study published pregnancy outcomes for 230 pregnancies and found similar rates of stillbirth and other outcomes such as congenital malformations, preterm birth and low birth weight when compared to a comparator cohort where the asthma was also moderate and severe, but no monoclonal antibodies were used. There are other registries now that are collecting information on other monoclonals in pregnancy. So the key messages for monoclonal antibody therapy are that patients who are already on monoclonals before they become pregnant should continue on these medications. However, the decision to start biologic treatment should be carefully considered and discussed with a specialist. So now I'm going to move on to think about self-management skills because it's all very well to have medications prescribed, but if they're not taken or not taken properly, then the value of these drugs will not be as great. So we know, for example, that only 4 in 10 women actually use inhaled steroids in pregnancy, 2 in 10 have optimal inhaler technique, 1 in 10 have a written action plan, and 3 in 10 understand what their medications are for. And these are not good figures, and there's certainly a lot of room for improvement in self-management. This slide here shows the results of a systematic review and meta-analysis that was conducted by our team, looking at all the studies in the literature, showing that overall 41% of pregnant women with asthma used inhaled corticosteroids. And these figures were slightly higher in Europe than North America, with Australia right in the middle. And this was also published alongside this in this systematic review. This is data that came from 8 European databases, and it shows the prevalence of dispensed prescriptions for inhaled corticosteroids in 3-month intervals. And you can see this dramatic drop in dispensing of inhaled steroids in early pregnancy. Interestingly, there's a rise again in the second trimester, which coincides with an increased prevalence in asthma exacerbations that's been documented in many studies, and a further decrease in the third trimester and, interestingly, into the first few months postpartum. This pattern has been demonstrated previously. This is data from 2006 from a US database showing a 23% decline in inhaled corticosteroids, a 13% decline in short-acting beta agonists, and a 54% decline in oral corticosteroids in that first trimester of pregnancy. So why might this happen? It could be because there is a perceived risk of asthma medications on the fetus. And we collected some data many years ago now where we asked women to rate on a visual analog scale, a 10 centimetre visual analog scale, what they thought the risk of Ventolin, inhaled corticosteroids and oral corticosteroids was for the fetus, from 0 being no side effects to 10 being severe side effects. And what we found was that at the first visit in our study, they rated the risk of relievers lower than controllers, lower than oral corticosteroids, as we might expect. When we asked women in a qualitative sub-study what they meant when they rated this perceived risk, 0 to 10% reflected no risk, 10 to 40% slight risk, and more than 40% quite a risk. And you can see that these perceived risks significantly decreased with self-management education that was given at each of these visits during our study. In terms of non-adherence to medication, so considering women who have been prescribed ICS and they use ICS, not those that have ceased use altogether, we also found that around 40% of women reported non-adherence in the previous week. With repeat education sessions, this was significantly reduced down to about 22% towards the end of pregnancy. Unfortunately, at 6 months postpartum, this had really jumped up again to 56% of women. This is one of the figures that's on the Asthma and Pregnancy Toolkit explaining a potential cycle of non-adherence where poor adherence to inhaled corticosteroids leads to worsening symptoms. A woman might then increase her reliance on her reliever medication. This might reinforce that her preventers aren't effective, leading to further non-adherence. Also on the toolkit is this table that's been adapted from a study we did in Newcastle, where women told us what reasons they give for not taking asthma medications. And we've provided on the toolkit some recommended solutions. So the number one reason women gave was that they didn't like the taste or they experienced throat or mouth symptoms. And this is something with inhaled corticosteroids that can be reduced by rinsing and gargling after using the preventer. And in the case of metered dose inhalers, using a spacer can minimise these symptoms. And unfortunately, the second highest reason people gave was that they thought it was unsafe in pregnancy. Some women felt that they didn't need to take it, or they were concerned about the dose. There were other side effects that women didn't like, and of course, people sometimes be forgetful. So what about overuse of short-acting beta agonists? This is some data from the Breathing for Life trial, which was conducted in 6 antenatal clinics in Sydney, Newcastle, Brisbane and Canberra. And we've had a look at the data based on whether women were using inhaled corticosteroids, shown in orange, or were not using inhaled corticosteroids in blue. And you can see that in the previous week, 76% of women using inhaled steroids also used a SABA. This was 52% for the women who were not prescribed or not using ICS. Those that used it more than 2 days a week, which is an indication that they might have uncontrolled asthma, was still very high. And among those who didn't have ICS, this was almost a third, and about 20% were using their SABA 7 days a week. And these are the median times per week that they reported using their SABA. So there's a group of women who are likely to need inhaled corticosteroids who are not using inhaled corticosteroids in pregnancy. Okay, so to just break up this talk a little bit tonight, I'm going to sprinkle in some very easy quizzes just to keep you on the ball. So to do that, I'm just going to stop sharing my screen for a minute, and I'm going to go over to the Mentimeter. If you go to menti.com, you can enter the code 86992823, and that should bring up the Mentimeter questions. Apologies while I just find this. So the first of the quiz questions is, what proportion of pregnant women in Australia have asthma? So if you're able to answer this now, we should see the answers come up on the screen. A few people are able to get on. I can see 5 on there. Janet, I'm not sure if you can put that in the chat, the code there, although it's now on the screen, so that's probably fine. Okay, so I'll keep moving in case there's only 8 people online or only 8 people willing to do the Mentimeter, which is totally fine. So yes, the majority of you got that right. 13% of pregnant women in Australia have asthma. So if we move to the next question, pregnant women are at increased risk of, is it preterm birth, vaginal birth, or long labours? We have a raised hand. I'm not sure, perhaps the person who's raised their hand could type their question in the chat if they're having trouble, perhaps with the Mentimeter. Okay, so yes, preterm birth has been one of the most studied outcomes in this population, and many studies have shown that women with asthma are at increased risk of this outcome. Having an exacerbation of asthma in pregnancy further increases the risk for, is it low birth weight, caesarean section, or congenital malformations? That's right. The risk of low birth rate is around 3 times higher in women who have an exacerbation compared to those who don't have an exacerbation in pregnancy. Okay, the next question is not coming up. Let's have a look. Okay, asthma involves inflammation and irritation of the lungs, making it hard to breathe. This is an easy true false question. Okay, there we go. Yes, that's correct. Okay, the next question, inhaled corticosteroids can be used in combination with a long-acting beta agonist. That's correct. In fact, they should only be used, the long-acting beta agonist should only be used in combination in people with asthma. Okay, bronchodilators reduce inflammation in the airways. Is this one true or false? Excellent. We have a smart crowd on board tonight. Okay, the next one is budesonide and fluticasone are considered the recommended inhaled corticosteroids in pregnancy because the options being there have been multiple RCTs demonstrating their safety. They're also considered safe in children. They are the least likely to be inquired about by women calling a medication safety service, or they have the longest history of use in pregnancy with the most reassuring safety data available. Unfortunately, there haven't been multiple randomized trials. There was one placebo-controlled trial of budesonide when it was first being developed that did include pregnant women. Incidentally, that trial published results for preterm birth, low birth weight, and other perinatal outcomes in about 300 women, but that's the only RCT that compared budesonide with a placebo. They were, however, used significantly in Scandinavia, where there are lots of large database studies showing their safety, particularly for budesonide. Okay, the proportion of pregnant women with asthma who use inhaled corticosteroids is approximately, is it 10%, 40%, or 80%? Okay, yes, it's about 40% across the world and particularly in Australia. About 40% of women use inhaled corticosteroids for their asthma. Monoclonal antibodies should be considered for use when a woman has already been taking them prior to pregnancy, a woman has very severe asthma not controlled with ICS, or both A and B. That's right. Yes, both of those conditions are true. Of course, if someone has very severe asthma that's not been controlled with ICS, but she hasn't been taking it before pregnancy, then that would require more specialist opinion. Okay, and I think this is the last one in this set. Recent research shows pregnancy is associated with the following changes in asthma symptoms. Is it worsening in 40%, no change in 60%, no change in any woman, improvement in 40%, worsening in 60%, or no change in 40%, improvement in 60%? Everybody was listening carefully. Yes, it was worsening in 40%, no change in 60%. Well, thanks everyone for that. I'm going to stop sharing that and go back to my other slides. Okay, and we're going to move on to talk a little bit about education, self-management education, particularly around inhaler technique, medication adherence, and reinforcing the importance of good asthma control in pregnancy.
Did you know only 2 in 10 pregnant women with asthma use the correct inhaler technique? Help women to get this medication to where it's needed. Well-controlled asthma is best for mums and babies.
Okay, so inhaler technique is really important, and that's because without good inhaler technique, the drugs don't get to where they're needed. So on this slide from Asthma Australia, you'll see that when somebody uses a puffer on its own, a lot of the drug ends up in the throat and even in the stomach, and a lot less in the lungs. But when a spacer is used, you can see that a lot more of that drug ends up in the lungs where it's needed. So I'm just going to stop sharing in a minute and hand over to Kelly and Janet. Kelly's our registered nurse who works with a lot of pregnant women with asthma, and she's going to demonstrate with Janet inhaler techniques both for puffers and spacers, turbuhalers and accuhalers. So I'm going to stop sharing that.
Good evening, everyone. What I'm going to go through with Janet is basically step by step the technique of how to use the most popular devices that are out at the moment. So we're going to go through the 2 different ways with spacers and a turbuhaler as well, and just a walk through with accuhaler. So essentially what I find at the moment is when people or women are doing inhaler technique, they usually miss 1 or 2 of the most important steps, which means they're not actually getting it into the airway for it to work effectively. So it's really important to actually encourage and check inhaler technique every single time that you see them, just to make sure that they're getting every single step correct. So we're going to go through the 1 puff, 1 breath method with the spacer. So essentially with this, what we get participants or patients to do is shake at least 5 times of the PMDI, pop it into the actual spacer, and then we actually get them to breathe out to the side, pop it in their mouth, press down once, take a nice deep slow breath in and hold for at least 5 seconds. 10 seconds is great, but 5 at the minimum if we can. So I'm going to get Janet to walk through these steps with this as well. So if you could give it a nice good shake. Breathe out to the side, pop it in your mouth, press it down once, big breath in, hold for 1, 2, 3, 4, 5, and then gently relax. Excellent. So that one's a quite easy and quick way to take the medicine, but what we also find is that, especially with women when they get towards the end of their pregnancy, it can be quite difficult to take a big breath in and also to hold it for at least 5 seconds. So that's why we also encourage the one puff, 4 breath technique, which was tidal breathing. So same again, shake at least 5 times, breathing out, pop it in the mouth, press it down once, and then it's just 4 normal breaths, whatever they're breathing at that time, 4 normal breaths, and then they can come off. So Janet, I'll walk you through that one again. So if you give a nice good shake, excellent, breathe out to the side, pop it in your mouth, press it down once, and just 4 normal breaths in and out, very relaxed breathing. Over the 4 breaths, the medicine goes in and sticks to the airways. Another 2. Excellent. And then she can come off. And then obviously repeating more, you repeat every step again by shaking it and then going forth. So the next one we're going to go through is Turbuhaler. This device here. So pretty much for this one, take the cap off, holding it upright. You need to turn it one way so you hear the click and then turn it back. Then we instruct patients to pop their head down slightly, pop the mouthpiece in the mouth with a nice good seal around it, and then take a nice forceful deep breath in and then hold it again for at least 5 seconds. 10's great, but at least 5. So Janet, if I can get you to holding it upright, turning it one way, turning it back, pop your head down slightly, breathe out to the side, pop it in, and big breath. Beautiful. Hold for 1, 2, 3, 4, 5, and then gently relax. Excellent. And then you pop the lid back on and it's done. The last one that Vanessa mentioned was Acuhaler. I actually don't have a device for that, but it's quite simple. It's not as popular that we see at the moment, but pretty much it just has a thumb grip, which you turn to the side. Then there's a bar that you again turn to load the device. Then again, blowing out to the side. We then ask participants to pop it in their mouth, take a nice big deep breath in, and then hold for at least the 5 to 10 seconds. And then because it's a powder, it's just a gentle relax after they're finished as well. So I'll hand you back to Vanessa.
Okay.
Only 1 in every 10 pregnant women with asthma have a written action plan for their condition. Help them manage it better with the Asthma in Pregnancy Toolkit. Well-controlled asthma is best for mums and babies.
All right, so we're going to talk now about written asthma action plans. And for that, I'm going to hand over to Kelly again.
So written action plans is an individualized plan for anyone who has asthma, but specifically we love women who are pregnant to have this so that they've got something to use as a guide if they do become unwell at home and what to do with their medications to prevent it from worsening. So this example here from Asthma Australia shows 4 different sections. In the green section is when women are well. So they're not needing their reliever medication for more than 2 days a week. No waking up at night, no waking up or in the morning. They can still do all their activities. There's a place there that you can actually put what dose of preventer that they need to have, and also reliever medications, for instance, if they need to take it before exercise. In the orange section is essentially when the symptoms have started to change or worsen. So the women might be needing their reliever medication more than 2 days a week. They start waking up at night. They start waking up in the morning with asthma, or they can't do all their activities as normal. There's actually a place there that you can put any changes to any preventers dose, any extra reliever medication, starting any other medication, but it also reminds them to make an appointment to see their doctor this week. In the red section, obviously, if they're using their reliever medication and it's not lasting for 3 hours, they're waking frequently overnight, having difficulty breathing. Once again, there's a place there to add any extra preventer doses and reliever doses, starting any other medications such as prednisone, but also it says make an appointment to see my doctor today. In an emergency, obviously in the red section down the bottom, obviously if the medication's not working, they can't speak full sentences, extremely difficulty breathing, lips turning blue. Obviously, we would remind them to call 000, not to drive themselves, but to start asthma first aid and keep taking their reliever medication until paramedics arrive.
Thanks, Kelly. And sorry, I had the video off there for your face for a little while. Okay. So one of the reasons why it's so important for women to receive good management of their asthma during pregnancy is that there's actually evidence from the literature that active asthma management lowers some of these poor outcomes. So the risks of preterm labour and preterm birth are actually lowered with active management. The same for neonatal hospital admission and gestational diabetes, as well as later development of asthma in the child. And importantly, the use of inhaled corticosteroids has not been associated with any increased risks of things like low birth weight or small for gestational age, preterm birth or congenital malformations. Okay, so moving on now to the next part of recommended management for asthma in pregnancy, and that is regular review. As I've mentioned before, symptoms change unpredictably, and therefore review of symptoms is recommended every 4 to 6 weeks. Now, how do we actually do that? And I'm going to talk briefly about symptom control assessment, and then around lung function using spirometry, and the measurement of FeNO, or exhaled nitric oxide. So this is an example of a symptom control questionnaire. This is the Pregnancy Asthma Control Test. It's almost identical to the other asthma control test, the ACT, where it has 5 questions asking about symptoms in the previous 4 weeks. And so the first question is around how much of the time did asthma keep you from getting as much done at work or home? The second question relates to shortness of breath due to asthma, and this is where the pregnancy-specific asthma control test comes in. They've added due to your asthma to distinguish from breathlessness of pregnancy. The third question relates to how often asthma symptoms have kept you up, woken you up at night or earlier than usual in the morning. The fourth question is around rescue inhaler use, such as salbutamol. And the fifth one is an overall rating, patient rating of asthma control. And for this test, a score of 19 or less indicates that asthma might not be as controlled as it could be. In terms of lung function and using spirometry in pregnancy, we'll just go through this in a little bit of detail. Spirometry measures the volume of air that the patient can expel from their lungs after a maximal expiration. And here's the normal volume time curve on the left, so showing that the FEV1 is the forced expiratory volume at 1 second, so how much air can be expired in the first second, and then the forced vital capacity is close to the total amount of air that can be expelled from the lungs. On the right is a flow volume curve. This is often the curve that the spirometer will produce as the test is being done. And you can see here that the big breath out produces this peak, and then we have an inspiratory curve shown here on the bottom. And the National Asthma Council has a spirometry handbook for primary care, which has a lot of good information in it. This slide here shows some of the data that we collected in a research study, which, just go back, which demonstrates that while there are some minor changes in FVC and FEV1 across gestational age, that these are fairly small and not of clinical significance. So these lines show the modelled values from individual data from 1,000 women, where you can see that women with asthma have a lower FVC and lower FEV1 as expected, but really not a lot of change over the course of gestation. So spirometry is still useful as a clinical tool in pregnancy. In terms of contraindications, however, recent eye, thoracic or abdominal surgery, aneurysms, unstable cardiac function, pneumothorax, chest or abdominal pain would mean that you would not do a spirometry. For pregnant women, nausea might be an issue to consider. The pre-spirometry checklist here shows that you should explain the purpose of the test and demonstrate the procedure. Ask the patient to empty their bladder if they need to beforehand. The patient's age, height, gender and ethnicity is important to record, as this is going to be used to determine what their predicted values are. People who are taller, for example, have bigger lungs and better lung function would be expected there. Note when the bronchodilator was last used. If it was used recently, that's going to influence their lung function, and the patient can sit comfortably to do the test without leaning forward. Now, these are the steps for performing spirometry, and I'm going to show you a couple of videos after this to show you what it looks like in real life. So people need to seal their lips around the mouthpiece, make sure the tongue's not in the way, breathe completely in until their lungs are full, and immediately blast the air out as fast and as far as possible until their lungs are empty. For an inspiratory curve, they need to breathe in again. And the process needs to be repeated to obtain 3 acceptable tests. So these tests need to be within 150 mils of each other to be considered acceptable. And you can see on the right here what that would look like if it was done very well, where the volume time and the flow volume curves are almost overlaid. Here are some real life flow volume loops. So from some of our studies, so if we look at the flow volume loop on the right here, you can see that the 3 curves are not overlaid. In particular, this lower one is a hill, not a mountain peak, indicating that they haven't forcibly expired as much as they could have. However, on this one here, you can see that the 3 curves are pretty much aligned. There's a little bit of a wobble in the curve, but that's really related to the individual's anatomy and not a poor technique. You can see here, again, from the National Asthma Council's handbook, you can see some of the errors that can cause problems with spirometry tests. So, for example, a submaximal effort will give the hill rather than the peak. A poor start is going to move the flow volume curve to the right. Coughing in the middle of the test will be a problem. And a submaximal inhalation, again, will mean that you don't get that sharp peak at the beginning of the flow volume curve. So I'm going to show you 2 videos now, and then I'll stop in case there are any questions specific to spirometry.
So what I'll get you to do for me first is if you can pop the nose please on. I'm going to hand that one to you. When you're ready, take a big breath in first. Pop in your mouth and keep going, keep going, keep going, keep going, keep pushing and pushing and pushing and pushing, keep squeezing it out. When you're empty, come off. Nose flip is off. And have a breathe. Well done.
Oops. Okay, we'll go to the next one.
Okay, so when you're ready, take a big breath in, pop it in your mouth, and run. Keep going, keep going, keep going, keep pushing, keep pushing, keep pushing, keep pushing, keep squeezing it out. And when you're empty, just take it out of your mouth. Okay, nose coming up.
Okay, are there any questions specifically on spirometry? If you could put them in the Q&A function, that would be great, if I can find that. Okay, no problem. We will move on to the next section. So I'm going to talk a bit about exhaled nitric oxide. So nitric oxide is produced by the epithelial cells that line the airways. And this means that an NO production is increased in the presence of type 2 inflammation. It's largely driven by interleukin 13, and elevated levels have been associated with exacerbations of asthma as well as corticosteroid responsiveness. And exhaled nitric oxide can be measured with a portable device quite easily with a 10-second exhalation. There's no forced exhalations in a FeNO measurement. And after a minute or two, a result can be obtained. Now, the reason why a FeNO test might be useful in asthma is that it's been shown to correlate with sputum eosinophils. And in pregnancy, we don't ever do an induced sputum test in women because that would deliberately lower their lung function. So for pregnancy, it's completely non-invasive, it's easy to perform, it gives a rapid result and is reproducible. There are several portable analyzers on the market. For example, the Niox Vero that you'll see in our video. And FeNO is now listed as a reimbursable test on the MBS when it's performed in a pulmonary function laboratory. The American Thoracic Society has got some guidelines on interpreting FeNO levels. So you'll see on this graph what's considered the normal range. It's quite a large range. People with stable asthma tend to have higher values, and the cut point for steroid responsiveness is considered to be 47 parts per billion. So I'll just play a video now on how this test is done.
To do this particular test, what I get you to do is turn your head to the side and breathe out first. Take a big breath in. A little bit harder. That's it. Try and keep that pressure. Keep going in between the two white lines. That's perfect. Keep going. Wonderful. Take it out. Gently exhale.
So as you saw there, it takes about 10 seconds of exhalation to complete that test. It's, as I said, it's not a forcible exhalation. You actually need to keep the pressure quite steady. It's quite a gentle breath out. So we're just going to stop again for a quick couple of questions before we move on to the next section. So I will just stop sharing for a minute and go back to the Mentimeter. Okay. And I will share the Mentimeter. Okay, so the next question is recommended management includes regular review of symptoms, involvement of the obstetric care provider, management of comorbidities such as rhinitis, and discussion of the importance of continuing medications. Too easy, these ones should all be done. So yes, if you're coming back to Mentimeter, the code is 86992823. Okay, the next one is FeNO is a surrogate marker of eosinophilic lung inflammation, true or false? Excellent. And the last one in this section, different reference values are needed for spirometry in pregnant women, true or false? So the data generally shows that there's no clinically relevant change in spirometry during pregnancy. So reference values can be used the same as for anyone else. So that's false for this one. Okay, I will go back to the PowerPoint. And we're going to talk now about multidisciplinary management and particularly the involvement of the obstetric care provider. And for this part, I'm going to hand over to Professor Michael Peake, who is a maternal fetal medicine specialist, to talk us through these slides. Thanks, Michael.
Thanks, Vanessa. We'll move on to the next one. And hi, everyone. So what I'm covering over the next few minutes is a bit about models of care, some points about labour and birth and the importance of breastfeeding. Now, before I move on to some of the models of care, I mean, I think we've got to remember that looking after women with medical disorders in pregnancy is a team event. Depending on the severity, it involves primary care, midwives, obstetricians, and perhaps the specialist respiratory team as well. Now, the thing about asthma and where primary healthcare is very important is, of course, the asthma predates the pregnancy and it's going to post-date the pregnancy as well. Plus, the children of parents with asthma are more likely to get asthma themselves. So there's a whole family that you have to consider to look after in the future. Now, as far as preconception care, I mean, what Vanessa's been going over throughout this whole seminar, included in the toolkit, are all the different areas you need to consider when looking at preconception care. And also with models of care too, is depending on your demographics, you've got to have to make sure your model of care is culturally safe, for your demographics. So thanks, Vanessa. We'll just move on. Now, when considering having, building up a model of care, I think you have to remember that there's not going to be one model of care that fits all situations. It's going to depend on your patient demographics, how many women you've got to look after, the resources both in the community and in the hospital setting, and what your women want for their care as well. But when you're setting up a model of care, I mean, it's education in asthma is very important. If you go back to the midwives, they've done surveys and data showing that the midwives, really want to get further education in asthma and pregnancy to carry out their role properly. Of course, being midwives and seeing the mothers up front, a lot of the time the mother's going to ask them questions. So I guess when you're starting up your models of care, you have to make sure that your team members are fully educated. Thanks, Vanessa. And this not just goes on beyond the midwives. I mean, surveys looking at the confidence, knowledge, and the use of guidelines, even among primary healthcare workers and specialists, could be better. I think what happens to a lot of doctors is, especially if they don't see a lot of pregnant women, they get a little bit unfamiliar on the physiology and the pathophysiology of diseases in pregnancy, and sometimes they lack confidence and knowledge in these areas. So again, you're setting up a model of care, you have to make sure that all your team members have the adequate education to carry out their work. Thanks, Vanessa. So what I'll just mention in the next few slides is just a few models of care. As I said, not one model is going to fit everywhere, and probably none of these models may fit what you need in Canberra. But it's interesting to look at how these different areas have put their models of care together and how they run them. So this first one is Randwick, the Royal Hospital for Women. How they work out their pregnancy asthma care for their women. If a woman has mild asthma, they're happy to have midwifery-led antenatal care, and then they communicate with the GP or obstetrician if anything more is particularly needed in regards to the asthma and pregnancy. For moderate asthma, the GP is the lead for those pregnant women, and they talk with the obstetric physician, if required. On the other hand, in women with quite severe asthma, perhaps needing biologics or who have a lot of exacerbations, these women go through a specialty high-risk obstetric physician clinic with the input from a respiratory physician. So that's just one way of doing, and that's what's being done in Randwick in Sydney. The next one is an overseas model of care. This is Manchester in the United Kingdom. How they do it is they actually divide their women whether they're well controlled or uncontrolled first up. So if you've got someone even with mild, moderate disease, but they're well controlled, that the antenatal care and asthma care is led by the general practitioner. While if it's uncontrolled with changes of medication and so forth, they have a general asthma clinic within their hospital setting that sees these women and goes on to, if they've got very severe asthma, goes on to see a severe asthma specialist in a multidisciplinary team, to work out the individualized care for these women. Thanks, Vanessa. So, getting back to Australia, this is where Vanessa and the team's from in Newcastle. And I mean, this is quite a specialised antenatal asthma management service. I guess, to be fair, it's been built up because the whole team and the University of Newcastle are very interested in research and education in this area. But what they're able to do is that all women with asthma have a first up consultation with a nurse specialist who goes through a detailed asthma history, looks at the knowledge the woman has in asthma with her self-management skills, what medication she's on, checks the techniques of her using her devices, like you've seen in the videos already, looks at the triggers for asthma and how it's controlled, and what other medical conditions that are associated with this, and gets all the information together. And then for a second consultation, all the women with asthma are seen by a respiratory physician who goes over all that information, reinforces education, and then individualizes care for that woman and works up what follow-up consultations are needed and with who. Now, that is a very deluxe model of care, but it can show you what can be done, for looking after asthma and pregnancy, the most common medical disorder in pregnancy. Thanks, Vanessa. Now, just a few points on labour and birth, and why I want to bring these up is really for when you're speaking to your pregnant women with asthma, you can be quite reassuring about what might happen in labour and birth for someone with asthma. Exacerbations of asthma are really very uncommon during labour and birth. To be honest, I can't remember the last woman I saw with a significant exacerbation of asthma during their labour and birth. So it's quite rare. But if they do have symptoms, the labour and the asthma are managed with just standard asthma therapies. What you do when you're not in labour, the same treatment. And of course, be very reassuring to women that asthma does not preclude a vaginal birth. And you really only end up with cesarean section for obstetric reasons rather than your asthma. And really to say that it's better to have a vaginal birth. There is some data, perhaps a little bit controversial, that cesarean section may actually increase the risk of a child developing asthma, but it's something to consider. It may be to do with changes in the microbiome, when you compare a vaginal delivery versus having a cesarean section. Now, of course, occasionally, women with very severe asthma may be advised to have an induction of labour or cesarean section at a time when their asthma is well controlled, but this is very, very rare. And when we do that, we make sure, the whole team is aware of what's going on. We also get the anaesthetists involved up front to make sure the best way we're going to provide an anaesthetic if they're undergoing cesarean section, or even if they may need a pain relief during labour. Again, to be reassuring, if someone did need an induction of labour, for other reasons, the standard ways that we induce people using prostaglandin E2 and oxytocin, or using catheters are the same with whether you've got asthma or not. What we try to avoid is prostaglandin F2 alpha, because this may lead to an increased risk of bronchoconstriction, but we don't usually use PGF2 alpha. So you can be very reassuring to your women with asthma that the labour and birth is usually not much different whether you have asthma or not. Thanks, Vanessa. So breastfeeding, really, really important. It's something we always talk about, but we really have to reinforce it. And when we reinforce, why we want to reinforce it is that breastfeeding, through lots of data, has been shown to decrease the risk of asthma in children, increase lung capacity, decrease the risk of wheeze and hospitalizations for asthma and wheeze for their children in the future. Thanks, Vanessa. And some of the data behind that, this is from Vanessa's group, who have done a systematic review, and it showed that you can reduce the wheeze in infants by about 32% by having breastfeeding of any breastfeeding, really. So there's significant improvements in your child's care with breastfeeding. Thanks. And again, looking at two of the cohorts that Vanessa's group's been involved in of pregnant women with asthma. Again, breastfeeding compared to no breastfeeding, or any breastfeeding compared to no breastfeeding, has significant improvements in ED presentations, hospital admission, etc. So it's something that's very, very important. Thanks, Vanessa. So the trouble we have is, even though we say all those things, that it can really improve the outcomes for your children with breastfeeding. If you look at the data, breastfeeding among women with asthma is below WHO recommendations. So we need to do something about this, because breastfeeding, as I've said, can really increase, it may reduce the risk of poor lung function in their offspring. So I guess what can you do to try to improve breastfeeding? Well, it's to talk about it with your women. It's to refer them on to a midwife, or perhaps a lactational consultant, to try to get things in place prospectively to help increase their chance of breastfeeding successfully. And again, also to be very reassuring that the most asthma medications are safe to continue during breastfeeding. So just because you're on asthma medications, you shouldn't, you should continue your breastfeeding. Thanks, Vanessa.
Okay, thanks, Michael, for doing that section. To finish off tonight, we're going to talk about management of comorbidities. And because I'm from the Centre of Excellence in Treatable Traits, we're going to talk about it in this treatable traits framework. So treatable traits are traits which are clinically relevant to asthma, they're identifiable and measurable, and they're treatable. And they fall under three broad domains: the pulmonary domain, the extrapulmonary domain, and the risk factor or behavioural domain. And this is what the page on the Asthma and Pregnancy Toolkit looks like. I'm going to talk from this pie chart around the traits that have known prevalence and clinical importance in women with asthma in pregnancy. And on the right-hand side, we have the traits with unknown prevalence and or unknown clinical importance in pregnancy. So there's a lot known around T2 high inflammation, airflow limitation and symptoms, and respiratory viral infection in the pulmonary domain, but nothing is known around breathlessness and dysfunctional breathing, or asthma and exacerbated disease, and how this might be important for women who have asthma in pregnancy. In the extrapulmonary domain, there's a fair bit of data around the role of obesity and excess gestational weight gain, depression and anxiety, and rhinitis, but no research or not a lot of research on reflux or sleep apnea. We know that reflux is more common among pregnant women with asthma than women without asthma, but little more is known. Sleep apnea and vocal cord dysfunction, there's no studies specific to this population. In terms of iron deficiency and hyperemesis, gestational hypertension and diabetes, we know that women with asthma are more likely to have these conditions than women who don't have asthma, but we don't know whether they're clinically important for their asthma. And vitamin D insufficiency has been shown to be very highly prevalent in women with asthma during pregnancy. But again, we don't understand fully its clinical importance. In the behavioural domain, there's been a lot studied around cigarette smoking, which is obviously not good for asthma or pregnancy. And as we've already talked about today, it's important that women have action plans and know how to use their inhalers correctly. However, we don't know anything from the research perspective about e-cigarettes or vaping. There's been no studies of physical inactivity or sedentary behaviour in women with asthma during pregnancy, although there are studies showing that these are important traits for adults with asthma. And very little has been studied in terms of nutrition or health literacy. So to talk briefly about some of the things we do know in a little bit more detail, asthma can be characterised as being T2 asthma, where type 2 inflammation is high. That's sometimes referred to as eosinophilic asthma, or non-T2 asthma, where type 2 inflammation is low, and that's sometimes referred to as non-eosinophilic asthma. And you can see on the pie chart here, this is a sample of 195 women where we looked at their FeNO levels and their blood eosinophils. And when those two markers were low, we characterised them as having non-eosinophilic asthma. And this was just over 50% of the women. And for these women, inhaled corticosteroids may not be as effective as those who do have high levels of eosinophils. And as I mentioned earlier around exhaled nitric oxide, I just wanted to share an example of where this has been used in pregnancy. So we conducted an RCT called the MAP study, where women were randomised to a control group where treatment was stepped up or down according to symptoms, or the FeNO group where their treatment was stepped up or down according to both their FeNO level and their symptoms. And they had monthly visits during the pregnancy where treatment was adjusted, and all 220 women were non-smokers. And what we found in this RCT was that exacerbations in pregnancy were reduced by 50%, with a number needed to treat of 6. Women were more likely to be prescribed inhaled corticosteroids using the FeNO-based approach, but at a lower mean dose. And women were also more likely to receive long-acting beta agonists in combination with their inhaled steroids. And this was mostly for symptom control. Just to finish off that story, we did do a larger trial in a real-world setting where we changed treatment every 6 to 12 weeks during pregnancy. We used a similar algorithm, but we did not find any significant improvement in perinatal outcomes, which was what we were primarily interested in the Breathing for Life trial. So more research is needed to fully understand how using pulmonary biomarkers can potentially improve asthma in pregnancy. Okay, the other part of the pulmonary domain that we know a fair bit about is respiratory viral infections, which are a common cause of asthma exacerbations in all people with asthma, including pregnant women. On the right, you'll see a graph of common colds occurring in women with and without asthma. So the women with asthma were more likely to have common colds across pregnancy. And when these colds were PCR positive in the lab, 1 in 3 of them were associated with an exacerbation requiring medical intervention. There's also been a recent paper from Denmark, a population-based study showing that women with asthma are at increased risk of SARS-CoV-2 infection and severe COVID disease requiring hospitalisation. So vaccination, therefore, against influenza as well as COVID, is recommended in pregnancy generally, but is particularly important for women who have asthma. In the extrapulmonary domain, anxiety and depression is one of the commonly studied traits. It's been associated with a 42% increased risk of exacerbations of asthma in pregnancy. It's commonly reported among 1 in 3 pregnant women with asthma, and has also been associated with uncontrolled asthma symptoms in pregnancy. So an important trait to consider in the holistic care of women who have asthma in pregnancy. In addition, obesity is common. In the same systematic review, we also found it was associated with an increased risk of exacerbation. And on the right, you'll see results from one of our prospective studies showing that women who were overweight or obese were twice as likely to have an exacerbation in pregnancy. Interestingly, that study did not show an effect of gestational weight gain, excess gestational weight gain on exacerbations, but another study from Europe has shown that interaction. In the behavioural domain, there are many behavioural traits that are common among pregnant women with asthma, particularly smoking, excess gestational weight gain, and suboptimal self-management. As I mentioned, less is known about physical activity. This figure from the toolkit shows on the left the reasons why physical activity is good for asthma. It's been associated with improved quality of life, less exacerbations and reduced symptoms, as well as reduced anxiety and depression. And on the right, in pregnancy, physical activity lowers the risk of gestational diabetes, lowers incontinence and back pain, and reduces the risk of postnatal depression. So it's likely to be a useful intervention in pregnant women with asthma who may be more sedentary than women who don't have asthma, based on what we know in the non-pregnant population. So to finish off tonight, I'm going to try and keep time for questions. I've just got a couple of scenarios to run through, which you can answer on the Mentimeter. So I'll just read out what the scenario is and then explain what to do next. So Naomi is 20 weeks pregnant. She's mentioned she has increased asthma symptoms. She's been prescribed Seretide 250/25, 1 puff twice a day, Ventolin as needed, which has worked well to control her asthma previously. She states she's not been taking her prescribed medication since her pregnancy was confirmed, as she is concerned about possible harm to the baby. So I'm going to flick over to the Mentimeter, and you can mark on that how strongly you agree or disagree with these statements. So just a moment while I get that up and running. Okay, I'm going to click back, share the screen. Okay, so should Naomi continue her current approach using Ventolin as needed? Naomi should be advised to restart her prescribed Seretide. Naomi's preventer should be changed to Pulmicort, or Naomi should be referred to another health professional for asthma management. These questions aren't necessarily right or wrong, but it'd be interesting to see how strongly you agree or disagree with these statements. So while Pulmicort is the only category A inhaled corticosteroid in pregnancy, the guidelines also recommend that if a woman has been well controlled on another inhaled steroid before pregnancy, that can be continued. So the advice to restart her prescribed Seretide is appropriate if she was well controlled on that prior to pregnancy. She could be changed to Pulmicort, but that's not necessarily needed if the Seretide was working for her. Okay. Now I'm going to have to flick back and forth. I apologise for this with the Mentimeter. I'm going to go back to the PowerPoint for the next scenario. So Flora is 37 years old. She's 12 weeks pregnant. Her pre-pregnancy BMI was 31. She has a history of moderate to severe asthma and has had 2 hospital admissions for asthma in the 12 months prior to becoming pregnant. She's prescribed Symbicort 2 puffs BD, but doesn't like to take it because of the taste. So again, I've got four statements where you can agree or disagree. Flora is at risk of having an asthma exacerbation during pregnancy. Flora's baby is at risk of being born preterm. Flora would benefit from using a tracking app to record her Symbicort use, and Flora should be advised to rinse and gargle after using her Symbicort. So Flora is at risk of having an exacerbation for several reasons due to her BMI, her prior exacerbation history in particular, and her baby is at risk of being born preterm primarily because she has asthma, but if she were to have an exacerbation then or require oral corticosteroids during the pregnancy, then that would increase that risk further. She may well benefit from using a tracking app to help her remember to take Symbicort, and rinsing and gargling will hopefully help with the taste. Now I'll just pop up the last one and then go back to the slides. So the third scenario is this one here. Henriette is 23 years old, 30 weeks pregnant. She's presented to emergency for the first time with an asthma exacerbation. She currently only uses Ventolin for her asthma and has been using it every day in the past month, using it 10 times in the past day. She doesn't have a current action plan for her asthma, as she rarely has symptoms since she was a teenager. So again, we have 4 statements. Henriette would benefit from using a preventer medication. Henriette should be considered for prednisolone if her condition deteriorates. Henriette requires an updated written asthma plan, and Henriette would benefit from having a spacer and being shown how to use it. Thank you to those participating in Mentimeter. Yes, Henriette sounds like she would benefit from using a preventer. That level of Ventolin use in the past day and month would suggest that. If she stays in emergency and her condition deteriorates, she should certainly be considered for prednisolone, just as any other woman with asthma would be considered for that. It's always good to give a woman an updated written action plan if she hasn't had one for quite some time, and having a spacer may help that Ventolin to be more effective. Okay, excellent. Thank you to those participating there. Okay, so to finish off, I just want to reinforce a few key messages. Treat asthma in pregnant women as you would for non-pregnant women, including maintenance medications, exacerbation management, and provision of a written action plan. Communicate with the woman's other care providers, and use and recommend the toolkit to colleagues and families. Now, when the slide changes here, I'm just going to also alert you to the fact that Asthma Australia has a 1-800 asthma line that comes highly recommended. And I'm going to hand over now to Janine Lorenz from Asthma Australia, who's got a few words just to finish off tonight.
Thanks, Vanessa. That's been a fantastic presentation. So I just really wanted to make everyone aware of our free service for your patients, and also the referral options available to healthcare professionals. So patients can refer themselves, or you can refer them. We've updated our referral system as well. So there's now, best practice, medical director and ZMed. You can go through that with clinical software. I'll also drop in the chat the link to our refer page. So basically, we continue the care that you're providing your patients, and we try to make sure that they're staying on track with their preventers and that they're heading back to you when they need that extra reinforcement or some management around their medications. Just the next slide, please, Vanessa. We also provide them resources. So we've got our own resources that we can provide them. And, you know, it's all about trying to give them those messages around looking after their asthma, which is going to be best for their baby. And the next one, please. Again, I'll pop those links in the chat, and feel free to reach out if you'd like any further information about the service. Thanks very much, Vanessa.
Thanks, Janine. So hopefully there's, I'm sorry we've gone slightly over time, but we will take some questions. Please put them in the Q&A if you'd like. I do notice the question that's in there already around spirometry. How would you say that this could be the same in pregnancy when we know that pregnancy hormones can relax muscle, including the lung, in a pregnant woman? So there's very little research on the relationship between pregnancy hormone changes and lung function. So while we do know that there are physiological changes with pregnancy due to progesterone, estradiol, etc., we actually know very little about how that affects the lung, how it affects exacerbations and asthma control. And I guess our studies of spirometry have shown that basically there's very, very little change in forced expiratory volume in 1 second and forced vital capacity across gestation, regardless of hormone changes. But certainly I think it's an area that needs a lot more research, because we don't, while pregnancy hormones are a potential reason why asthma changes, we don't know how they relate to changes. And we also know that generally fewer women have an improvement in their asthma during pregnancy than have a worsening. So worsening is much more common in pregnancy. The role of the peak flow meter, thanks, Paul. Many action plans used to have a spot where you could record your peak flow. And for some women, this might still be very appropriate. Peak flow meters are easy to use, and women can, see that change in their peak flow, which might signal that they're about to have an exacerbation and they might need to take action. So certainly a peak flow meter can still be recommended or used by women, usually for women with more severe disease. Now, I'm just going to move to the next slide. Please feel free to keep adding questions. I would encourage you to please complete the post-workshop survey. If you previously bookmarked this page or emailed it to yourself, just use that page. If you didn't do the pre-workshop survey, that's fine. You can access the post-workshop survey here with the QR code or the red cap link. I'm going to leave that on the screen for a few minutes, and if there's any further questions, feel free to pop them in the Q&A. Thanks so much for participating tonight. I hope this was a useful session for you. And I'd encourage you to check out the Asthma and Pregnancy Toolkit, recommend it to families, and keep asthma on the priority list. I know there's often many other priorities for pregnant women, but asthma is important and can be well managed, and good outcomes can be achieved that way. Okay, is there any evidence that omega-3 supplements during pregnancy reduce asthma in the offspring? I don't want to give a definitive answer on this in case I get it wrong. I know there have been studies of fish oil supplementation, as well as other studies of other nutrients like vitamin D, that have had mixed results in terms of reducing asthma in the offspring. I'm not 100% familiar on the omega-3 studies. But often what's observed is perhaps a reduction in wheeze in early life and then no change in asthma at an older age. But I know there were studies by Hans Bisgaard's group in Copenhagen looking at fish oil supplementation. So apologies that I don't have that information on the top of my head. certainly nutritional supplements are important to consider and may well be useful in thinking about asthma in the offspring. Who is eligible to do a written asthma plan for pregnant women? My understanding of this is that general practitioners and other doctors are able to do action plans. However, I understand that the scope of practice for pharmacists is going to be expanded to allow pharmacists to write a written action plan as well. Thank you very much for your questions and participation tonight. I'm going to wrap up the webinar here, but feel free to get in contact with us if you would like via the Asthma in Pregnancy Toolkit. Be happy to answer further questions that way. Thank you so much.